Hi everyone, my name is Ashley Miller. I'm an intensive care consultant in the United Kingdom. Thank you to Dr. Roller for inviting me to share some thoughts with you all. I'm going to talk about why we need to forget the term fluid responsiveness and instead think about mean systemic pressure responsiveness. I have no conflicts of interest. Now, the way we've resuscitated patients over the last 50 years or so has seen very gradual but significant changes. Back in the 1960s, we started out with trying to maximise oxygen delivery, as suggested by Shoemaker and colleagues. To do this, we tried increasing cardiac contractility, reducing afterloads, giving blood transfusions, but most of all by administering lots of IV fluid and aiming for supranormal CVP levels in an effort to increase cardiac output. And this was demonstrated by the results of the early goal-directed therapy trial back in 2001, where not just the experimental but also the control groups received 14 litres of fluid in the first 72 hours. This was normal practice at the time, and the approach became enshrined in the Surviving Sepsis Campaign guidelines. Little thought initially was given to whether patients would actually respond to the administered fluids. In fact, predicting fluid responsiveness had been noted in the 1980s by the assessment of dynamic changes in blood pressure with respiration. When intrathoracic pressure changes, the preload and afterload of the ventricles change, and this is manifested by things like systolic pressure variation, pulse pressure variation, stroke volume variation, and IVC or SVC diameter changes, or an end expiratory occlusion test. But it wasn't until the 2000s that this concept of fluid responsiveness began to get real attention. It became recognised that only around 50% of critical care patients increased their stroke volume with a fluid challenge, that static parameters like central venous pressure and ventricular size were not at all predictive, and that it was those dynamic parameters that were specific, providing certain preconditions were met. These preconditions unfortunately mean, though, that in the real world, these dynamic predictors of fluid responsiveness are limited in usefulness, as demonstrated in the paper the QR code will take you to. But thankfully, we could get around this problem by giving volume with IV fluid, or even better, a fully reversible passive leg raise to see if stroke volume or blood pressure increased. And this practice did perhaps help prevent non-fluid responsive patients getting more fluids, but also meant that the states of non-fluid responsiveness began to be targeted. Clinicians would give fluid until a patient was no longer responsive and think they had optimized their patient's cardiovascular system. We thought we were providing cutting-edge ICU management, but our patients still ended up getting loads of fluid and looked like this as a result. Fast forward a few more years, however, and trials proving the uselessness of early goal-directed therapy, the FEAST trial showing fluid boluses increased mortality, and a whole host of evidence associating a positive fluid balance with worse outcomes has meant practice has been changing in recent years with a focus on de-resuscitation. But all this de-resuscitation stuff is still based on the fallacy of looking for fluid responsiveness, overloading the patients in the name of optimization, and only a few days later aiming to take the extra fluid off. And for the last 20 years, there's been paper after paper and conference talk after conference talk about fluid responsiveness. And 20 years ago, this was new and interesting. But now I find it a bit depressing, as it ignores physiology and common sense but even worse, harms our patients. A way of thinking summed up so well by Alice in Intensive Land. So, let's take a look at some simple physiology. Guyton's work in the 1950s illustrated how in health the circulation is under peripheral control, which is permitted rather than determined by the pumping action of the heart. But misunderstandings of how blood gets around the body still persist today. Graphs like the one above, based on Guyton's experiments, suggest things to us that aren't true, like CVP being the cause of cardiac output rather than its effect, or cardiac output being increased by increased inotropy, which in fact only happens in heart failure. Control of the circulation has perhaps best been illustrated by a cardiac surgeon called Anderson, who demonstrated the physiology he saw in his cardiac surgery practice with a hydraulic model he created, showing us how the circulation is actually controlled. Unfortunately, his work didn't become widely known, as it seems he was more interested in teaching than publishing. But you can see a video of this model working on YouTube, and you can get free access to his online textbook. The circulation being under peripheral control can be conceptualized by thinking what has been variously termed mean systemic pressure, or PMS for short, mean circulatory filling pressure, cardiovascular filling pressure, venous excess, and stressed volume. And these are all slightly esoteric concepts, which is perhaps why there's so many terms for a similar idea. So mean systemic pressure, for example, is a pressure that only exists in a state of no flow. But essentially all these terms mean is that the pressure gradient that exists between the small veins and the right heart controls venous return, assuming that is that the heart isn't failing. Because of this, we can think of mean systemic pressure as being equivalent to an average pressure of the small veins. But as mean systemic pressure is a term in common usage, we'll stick with that for the purposes of the talk. But if you find it confusing, just substitute the term venular pressure. Now, this pressure results from the proportion of blood that's exerting pressure on the vessel walls, which is why the term stressed volume is also used. And this is, of course, how fluid responsiveness works. Increased volume in the small veins increases their stressed volume and pressure, and flow back to the heart increases. And this pressure that causes venous return is determined not by how hard the heart is pumping or the pressure in the arterial system, but simply by the volume and compliance of the small veins where most of our blood is located. So said in another way, it's the tone of the small veins and the volume within them that determine cardiac output. A normal heart will happily move forward whatever flow comes into it and keep right atrial pressure low within certain constraints. So fluid responsiveness exists when increased volume in the small veins increases the pressure gradient for venous return. We can define fluid responsiveness as a significant increase in stroke volume, commonly 10 to 15%, after a volume challenge. Now, whether this be IV fluid administration or shifting volume from the legs to the central circulation by a passive leg raise. But there are a number of problems with fixating on the response to a fluid bolus. Firstly, all humans with myocardial reserve should increase their stroke volume with a volume challenge. It's not a specific sign of hypovolemia, vasodilatation, or being ill in any way. It's normal. Giving fluid to someone until they are not fluid responsive means you have massively fluid overloaded them. It takes a lot of volume to overwhelm the compliant right heart and venous system. Secondly, fluid responsiveness in the absence of hypovolemia is transient. After 30 to 60 minutes in a healthy volunteer, or as little as 15 minutes in a vasodilated patient, stroke volume and blood pressure will return to baseline after a fluid challenge as the fluid redistributes from the vessels to the interstitium. In non-hypovolemic patients, it's irrational to think this transient response can be of any benefit. Thirdly, focusing on volume responsiveness forgets that compliance is more likely the problem. Hypovolemia is actually pretty rare in hospitalised patients. Almost exclusively, it only exists in those with significant GI losses or bleeding. If we ignore cardiac problems, then the vast majority of hypotensive patients in hospital are vasodilated from a systemic inflammatory response, usually resulting from infection or major surgery. Fourthly, it's much less widely appreciated that the signs of fluid responsiveness demonstrated in multiple studies are just as much signs of vasopressor responsiveness. So swings on arterial line traces, stroke volume variation, pulse pressure variation, hyperdynamic echo images, small variable IVCs, etc. are simply signs of a low mean systemic pressure, which again can be a volume or compliance issue. Whether fluids or vasopressors are more appropriate depends on the pathology. Is there hypovolemia or vasodilatation? So, if mean systemic pressure is made up of volume and compliance, and volume problems in patients are rare, why on earth do we talk so much about fluid responsiveness? If we were only going to pick one of the two determinants of mean systemic pressure, it would make much more sense to talk about vasopressor responsiveness. Rather than give someone a fluid challenge, it will usually be more appropriate to give a vasopressor challenge. Now, I appreciate, of course, that for patients on normal wards or first presenting to hospital, fluid is much easier to administer than vasopressors. But this doesn't mean it's the right thing to do, however. It is sometimes, but not most of the time. Vasodilated patients need vasopressors to restore venular tone, not fluids that will at best only have a transient effect on mean systemic pressure. We should treat the cause of the problem and not volume overload patients for no benefit. In case you're wondering if there are any studies on vasopressor responsiveness, then yes, there are. There's one on the screen right there. But you can easily observe this in action on any of your shock patients on your ICU. I'm going to show you two cases where I actually recorded the numbers that I observe all the time in my practice. And please note, these patients weren't carefully selected by me. These were the first two shock patients on my ICU that I went and recorded numbers from for the purposes of this talk. You will easily be able to demonstrate the same effects in your patients if you have any kind of cardiac output monitor by turning vasopressor doses up or down. So let's go to our first case here. So this was a patient who was ventilated on the intensive care unit on a moderate dose of noradrenaline, or norepinephrine for those of you across the pond. Echo showed a hyperdynamic heart, and the patient had a positive response to a passive leg raise. So blood pressure and stroke volume both went up with a passive leg raise. So you can see here the patient's hypotensive, which clearly needs treating, and we can see lots of signs of fluid responsiveness. So, needs fluid, right? But this patient had no cause for hypovolemia. The passive leg raise, stroke volume variation, and the hypodynamic heart are simply signs of mean systemic pressure responsiveness, which in this case was much more likely to be a compliance issue rather than a volume one. So what I did was increase the noradrenaline. And this is what happened. The blood pressure went up, the stroke volume went up, the cardiac output went up, and the stroke volume variation went down. The patient was mean systemic pressure responsive, and vasopressor responsive specifically. Would they have responded to fluid? Almost certainly. Would this have been sustained? Definitely not. Would fluids have been of benefit? No, they would have only contributed to fluid overload. Next patient. So patient in their 60s, on the intensive care unit with some kind of infection, ventilated, have been there a few days, they're moderately edematous, oliguric, and in fact on renal replacement therapy, removing 100 mL an hour of fluid. On a moderate dose of noradrenaline again, an echo shows again a hyperdynamic heart. There's also what looks like a significant swing on the arterial line trace. The central venous pressure is 6, so not high, and no signs of venous congestion on ultrasound, which you wouldn't expect anyway with a CVP of 6. So the blood pressure's okay, but there's an acute kidney injury, isn't there? Perhaps there's hypovolemia and too much vasoconstriction. Perhaps the 100 mL an hour fluid removal is too much. So let's do a passive leg raise. I did a passive leg raise and the cardiac output monitor I had attached showed these numbers. The stroke volume went up significantly, the mean arterial pressure went up significantly, and the stroke volume variation went down significantly. So fluid responsiveness has been clearly demonstrated there. So again, needs fluids, right? Well, is the patient hypovolemic? This wasn't plausible. The patient was edematous, and 100 mL an hour fluid removal is way below the capillary refill rate you would expect in an edematous patient. Now, in fact, overnight this patient had had a fluid challenge, and that had reduced the noradrenaline dose. But this only lasted for less than an hour. And then the noradrenaline dose went straight back to what it had been before the fluid challenge. So perhaps this patient isn't hypovolemic and would show a good response to a vasopressor challenge. So just to illustrate this, I increased the noradrenaline a little bit, and it resulted in almost identical increases in stroke volume, cardiac output, mean arterial pressure, and a similar reduction in stroke volume variation. Now, the mean arterial pressure was in fact okay, so more vasopressors weren't needed, but it did nicely demonstrate increased venous return with vasopressors. And what I actually did here was increase the fluid removal from 100 to 300 mL an hour, with the noradrenaline back on the original rate. Not only did the noradrenaline dose not go up over the course of the day, but it actually decreased, demonstrating that there couldn't possibly have been hypovolemia. So let's summarize what I've talked about over the last 20 minutes. So point 1, cardiac output is determined by mean systemic pressure, assuming that there's some cardiac reserve. Mean systemic pressure is determined simply by the volume and compliance of small veins. Fluid responsiveness is entirely normal, meaning that fluid unresponsiveness is a pathological state. And in the absence of hypovolemia, fluid responsiveness can only be transient. Shock is usually a compliance problem rather than the volume problem. And signs of fluid responsiveness are just the same as signs of vasopressor responsiveness. And all these points make a really good example for why monitors are never shown to improve outcomes in studies. So imagine the following scenario. You have a shock patient and you echo them and it shows a small hyperdynamic heart. You demonstrate an increase in stroke volume with a passive leg raise and end up giving them a fluid challenge, which leads to a transient improvement. But this has to be frequently repeated to keep the blood pressure up. The next day, your patient's oxygenation is worse and they're developing an acute kidney injury. You stand there and think, well, I've done everything I could to optimize this patient and they've got worse despite my expert use of monitoring. Whereas in fact, your false interpretation of what your monitors told you has led to patient harm. So anyway, the term fluid responsiveness can just get in the bin or trash. It's not helpful. It demonstrates a misunderstanding of physiology and leads to patients getting fluid overloaded. So instead of fluid responsiveness, think about mean systemic pressure responsiveness, understanding that increasing venous return is more often about giving vasopressors rather than giving fluids. So if you want to start using that term in papers you write and stuff now, you can credit me for it and that'll be brilliant. I'm joking. So thanks for listening. I have another talk at this conference about organ perfusion, which has overlapping themes with this, and I very much hope you'll enjoy that as well. If you've found this useful, I have some other talks on YouTube that QR code will take you to, and please do follow me on Twitter for some educational material. Thanks a lot. Bye.